Good evening, everyone. Thank you so much for joining us tonight. Welcome to our American Migraine Foundation webinar, which we're calling Navigating the Current Migraine Landscape and Emerging Treatments. My name is Dr. Claire Sandoe. I'm going to be facilitating tonight. I am a headache neurologist at the University of Toronto, as well as co-chair of the American Migraine Foundation's editorial board. And we have two phenomenal panelists with us tonight. I'm going to introduce them in just a second, and then I'll tell you about the structure of our evening. So our lovely panelists tonight are Drs. Nina Riggins and Teshamae Monteith. Dr. Riggins, who is an MD and PhD, is a board-certified neurologist at the Headache Center of Excellence in VA Palo Alto, California, as well as a UCNS certified headache specialist. She completed internal medicine internship at Texas Tech, neurology residency at Penn State, and a neurophysiology fellowship at SUNY Buffalo, followed by a headache medicine fellowship at the University of California, San Francisco. She has quite a lot of leadership and editorial roles for a number of important societies, the International Headache Society, American Headache Society, American Academy of Neurology, and she's a board member of Miles for Migraine. She has a lot of other accomplishments that are too long for me to list here. Dr. Teshamae Monteith graduated from medical school at the University of Miami and did a neurology residency at the New York University School of Medicine, then a headache fellowship at Thomas Jefferson University, followed by a second fellowship at the University of California, San Francisco. And she's currently a professor of clinical neurology, as well as chief of the headache division and headache medicine fellowship director at the University of Miami Miller School of Medicine. She also has several leadership roles in the American Headache Society, International Headache Society, and I get to work with her as my co-chair for the American Migraine Foundation editorial board. So I'm really looking forward to our discussion tonight. We're going to talk through a number of topics, and then at the end, we're going to take as many questions as we can. We know that many of you have already started to submit questions, which is excellent. Please do keep submitting questions as they come up and occur to you. We'll try our best to answer all of those. Unfortunately, we're not able to provide personal medical advice, but we'll try to answer as many things as are of interest to you, our audience tonight. And thank you again for joining us. So we are going to just kick it off with a general sort of look at where we are in terms of migraines today. And so Dr. Riggins, could you start off by telling us just a little bit about migraine in general? How common is it and what is the impact of migraine?
Thank you so much for this great introduction, and I'm so happy to be here. We love talking about migraine because migraine is second leading cause of global disability. We have more than 1 billion people in the world living with migraine. In the United States, 1 in 4 households affected by migraine. And we know that women affected by migraine more frequently than men, but even kids can have migraine. So we need treatments for everyone, for kids, for all our people living with migraine and other headache disorders. There is big unmet needs discussion. Example would be one of the published studies where they look why our patients who live with migraine stop in acute medications. It was interesting to see that 40-something% of these patients, they went to non-prescription medications. And then many people, they discontinue acute treatments for migraine because they couldn't tolerate it because of side effects or because they were not effective. So even this study on its own shows that we need more treatments for our patients. And we have many more studies coming up which showing that we do have big room for better preventive medications. And what we're doing nowadays to meet these needs, we're trying to do a lot of education. And I know that Dr. Monteith was with me on committee today for helping us to do better examinations, good examination for future headache specialists. And we need to train more headache specialists. And we're working with multiple patients and interprofessional organizations to provide better access to care. So thank you everyone for being here.
Thank you, Dr. Riggins. Then that's a nice sort of leading into what is it that we're trying to do for our patients with migraine. Dr. Monteith, maybe you can tell us what our goals of care are for people who have migraine.
Yeah, so I mean, our goals of care are to make people that have migraine live as normal of a life as possible and to achieve their dreams and goals, right? And so while having migraine, knowing that migraine is a very disabling disorder, that is not easy to do because we know it affects all realms of life, your social life, your academic work life. In between migraine attacks, we know people can suffer. So broadly speaking, when we think about interventions, we think about acute interventions and preventive interventions. And the goals of care for acute interventions, first of all patients with migraine should have some access to acute intervention. It doesn't have to be a pharmacologic agent, but oftentimes it is. And the goal of care for acute agent would be fast relief, sustained relief. You want your migraine to go away quickly. You want it to remain away, and you want to return to a normal function very quickly. And you want your treatment to be very consistent. So the majority of times you take it, you want to have an excellent response, not half the times, not a quarter of the times, but the overwhelming majority of time. You want a treatment that's not going to cause you side effects, that's not going to be costly, and you want to be able to not just take care of the headache, because we know that migraine is more than just a headache, but there are associated symptoms with migraine, and that includes nausea and vomiting, light sensitivity, sound sensitivity, but there are other symptoms too. There's fatigue, there's brain fog, there's lethargy, there is a neck stiffness that people may have. So all of these symptoms are important to control for goal of care for acute treatment. And then for prevention again can be pharmacological or non-pharmacologic. And the general goal of care for prevention is to prevent attacks, the frequency of attacks, the severity of attacks, the duration of attacks. In addition to those basic things, preventive medicines also may help acute treatments work better. So you may need less acute treatments if you have good prevention on board. So that's really important. And you want a treatment, again, that is not associated with side effects, that's well tolerated, and can get you back to the quality of life that a patient deserves. So there are acute goals of care, there are preventive goals of care, and there's a lot that we have in our toolbox to try and get patients a better quality of life.
Thank you. I think it's important for us to talk to our patients about those goals. I still have patients come to me who say, I'm fine, I take my medication and then I sleep for the rest of the day, and that's okay, right? And it's so sad that this is something people have normalized. It's okay, all of this impact from migraine. And so as you've nicely laid out, our goals actually are loftier sometimes for patients, and we hope to do better than this. Do you think we're there? We're going to talk tonight about where we are there and where we're not necessarily there.
That's a great point, that you have to talk to your patient, because what someone's goal is not what another person's goal is. And when you think that, wow, this might be my goal, that might not be what that person is interested in. So to be able to understand what those goals are can then help you tailor a treatment plan based on those goals.
Absolutely. And maybe you can continue, please, Dr. Monteith, by telling us about some of the strategies we use to figure out how to do that in terms of our treatment strategies and the guidelines that we follow.
Yeah, so I think the first thing is obviously taking a very good history, understanding that migraine is more than a headache, that it's a multiphasic disorder. So a good evaluation includes understanding symptoms even before the headache may start, and that might include aura or visual disturbances or other transient neurologic symptoms. Prodromal symptoms are getting a lot of attention now, and these are symptoms that if patients are able to identify, this may be the first sign that a migraine attack is going to occur. And there are newer treatments that are now targeting these earliest signs of a migraine, which means that it may prevent headache. So, of course, we have the postdromal phase. After the headache is gone, people may feel sluggish. They may feel worn out. So evaluating patients' phases of their migraine attack is very important. Their interictal burden, that's the period of time between attacks that maybe they have light sensitivity or other issues or concerns. And so some of the strategies are targeting these phases, eliciting for triggers. We're not always able to identify our triggers, but we know that there are many people that have triggers that they may not realize. The problem with triggers is that they're not always consistent. So it could be, for example, that an acute period of stress may trigger a migraine one time, but not consistently. The stress letdown phase is actually a more common trigger than the actual acute stressful event. Changes in sleep, especially when people have prolonged disturbances due to crazy schedules, can be a problem for many of our patients. So getting the triggers, hormones is another one. That perimenstrual period, we know that 2/3 of women have headaches associated with their menstrual cycle, and many people are underdiagnosed. It's not until you actually do a careful diary can you sometimes make that association. So trigger evaluation is important, sometimes not fully impactful, and then understanding what treatments people are using and what their goals and treatment needs, as mentioned, because we know that there are a lot of people that are on acute treatments, but they're not fully responsive. There's a lot of unmet needs. Almost all patients have some unmet need to their acute treatment. And then for prevention, it's about tailoring their preventive therapies, which again doesn't have to be pharmacologic, but can be vitamins. It could be non-specific treatments. We know that there are non-specific things that can be helpful: anti-seizure drugs, blood pressure medicines, antidepressants. Even if you're not depressed, may be helpful. And we have now newer migraine-specific therapies that might be helpful for our patients. So determining where our patients are, getting the diagnosis is very critical, and really trying to assess what that true migraine burden is.
And I want to highlight for our audience as well that we have some good tools as part of the EMF website to help find a healthcare provider who specializes in this, which I would direct people to if you don't currently have a provider and you're searching for one. And maybe just getting back to that trigger thing very briefly, because I absolutely agree many times it's important to find those modifiable triggers. But then I also, you may find this too, some of my patients live really restrictive lives because they're worried that it will be their fault that they have their next attack. And we've learned some interesting things about the prodromal phase and what may or may not be a trigger, like chocolate, for example. Can you comment on that briefly?
Yeah, so that's a really good point. A migraine attack is not your fault. It's a neurologic disease. That would be to say that a stroke or dementia or a multiple sclerosis is a person's fault, or an inherited disorder. It is an inherited disorder. So regardless of what you do with your life, you have, if you have migraine, you have an inherent vulnerability to have migraine attacks, which may be triggered by physiologic changes with age, environmental changes like the weather that you absolutely cannot control. People have migraines in New York, they have migraines in Canada, they certainly have migraines in Florida. So we can't necessarily control these things. And so trigger management is important, but we certainly shouldn't be a slave to them because they're not consistent. And sometimes, as you say, what we think is a trigger, a sensitivity to light, may be the earliest sign that a migraine is actually happening. And that is something, even chocolates, that some people crave certain sugars or salty foods, and they think, oh, I ate this, then I must have a migraine. That might be true, but it might also be that that actual craving is a warning sign that a migraine is actually going to come on. And there are a number of really wonderful guidelines now that are out in the literature. The International Headache Society has some practice recommendations. The American Headache Society has also put out some recommendations about treatment strategies for patients with migraine. Some of this includes starting CGRP monoclonal antibodies. These are targeted therapies for migraine, and a lot of people that are on that are patients have maybe already been on some of these treatments. The recommendations are starting to move towards using some of these migraine-specific treatments earlier.
Absolutely, and that's what I hoped we would talk about next, in fact, is some of these more recently approved therapies. Dr. Riggins, can you start by telling us a little bit about the CGRP targeted family?
Yeah, we are so glad to have them because it's migraine-specific treatments. And in our mind, we divide them to these big molecules, that antibodies, and they block in CGRP, and they're usually preventive. They stay in our body for a long time. One of examples when we have to keep it in mind, when someone prepared for pregnancy, we ask him to stop them 5-6 months prior to trying to get pregnant. So that's how long we think they have action in the body. And then we have GPANs. GPANs distinguish from these big molecules that they do affect liver and what other medication going through liver. So we do have to keep in mind that GPANs interact with other medications. The wonderful side and wonderful new philosophy since we got GPANs, that they can be preventive and acute. In the past, it was really tricky to decide when to take, for example, triptan, because we would say, oh, you have to take medication as soon as migraine attack starts, but then we have to limit it to about 8 days per month to avoid medication overuse headache. And it was very tricky to decide, and we would say, let's judge on functionality for this day. And so GPANs, we just can take when attack starts. There is wonderful article coming from Dr. Lipton's research about ubrogepant, which actually helped people to function better when was taken in premonitory prodromal stage, even before headache started. And article emphasized that goals per American Headache Society would be functioning well, and many people reported that when they took GPANT earlier in early stage of migraine attack, it was better. Migraine control better, and we don't believe that GPANs lead to medication overuse headache. So those are wonderful medications to keep in mind. So rimegepant approved by FDA for acute and preventive migraine. We have another GPANs which approve atogepant, approved for preventive migraine. And then we have GPANs including one as nasal spray, which acting acutely. So we using all these tools. We do keep in mind that literature shows that GPANs may be cinch less effective in general than triptans, but their side effect profile usually better. So that's something to work with your clinician.
Great. And is this something that you're using routinely in your patients currently, Dr. Riggins? How are you positioning those therapies?
I try to prioritize those medications because they have less side effects, and I definitely appreciate American Headache Society statement that we don't have to go through other steps when we feel that this medication appropriate. I do appreciate data coming, for example, one of the studies done by Dr. Godsby and team in tertiary headache center, and they show that triptans also have some significant failure rates. So people did not respond to triptan, to 2 different triptans, to 3 different triptans when they were treated in headache centers in pretty big proportions. And so we do need these other medication choices. And example would be non-steroidal medications when we don't have side effects from them or contraindications, and of course GPANs in addition. At times we do have someone who benefits from triptans, but the people have more headache days per month which can benefit from GPAN. So I sometimes combine triptan and GPAN in the treatment plan to make sure that the person has as little migraine attack affecting their life as possible. So I absolutely enjoy having those medications in our toolbox. Another example of tricky situation in the past would be someone maybe with less functioning of the liver. And those big molecules, they don't go through the liver. So CGRP antibodies, they get disintegrated in blood by specific system. So it's very nice to keep in mind that now we have something to offer for the patients who we were very hesitant to start any medication which can affect liver or cause drug-drug interactions. For example, one on multiple other medications. So CGRP blocking antibody usually does not interact with other medications. So it's a lot of different positive things, but then again, nothing is for everyone. And we sometimes start with one and we give it good try. So we don't usually just stop it next month. We keep in mind that all preventive usually can take 2, 3, even 4 months to show the effects. And if no side effects, we would just recommend on average 3 months to try. And if it didn't work, then we consider maybe we go to different medications. So we work very closely until we figure out what's the best treatment plan.
Mm-hmm. And I think we could probably talk about this new family for several hours, but maybe just in the interest of the time that we have in hand, Dr. Monteith, does it make a difference to your patients when you tell them these are migraine-targeted medications?
Yeah, I think it does. I think for some patients, it really makes a difference. Not everyone gets that same, this is exciting. I think patients want to feel better. And I think the drug class or, doesn't matter as much as I want to feel better. So when you tell patients that you have a much higher chance of feeling better and having less side effects with this drug class, and then it's easier to use some of these drugs like the injectable therapies that Dr. Riggins mentioned are once a month injectables. So there's a convenience to them, less side effects and better efficacy. So yes, I think it does have an impact to say that these are drugs that are targeted and meant specifically for me, but more important than that is that they work. They work and they don't cause me side effects. I mean, I think people would drink water if water helped a migraine, right?
And so, water does help.
Well, not everyone, right? I also have had people that are in the ICU because they drank too much water, and so, I think my point is that people would take what they could if it was safe and effective. And so, yes, I think it does make a difference, but more important is the efficacy and the safety.
I think that's a great point. And we're always trying to keep what our patients want and hope for in mind with all of these advances that we're doing. Dr. Monteith, can you tell us about some of the other more recently approved things, like some of the newer devices?
Yeah, so the devices, I think, is a very cool area to migraine and to something to be able to offer our patients. There are 6 FDA cleared devices that are available for migraine. They all work for acute treatment, have some clearance for acute treatment, and the majority of them have clearance for prevention. And so basically they work by targeting the peripheral nervous system, and by targeting the peripheral nervous system, there's crosstalk and in interaction with the central nervous system. And so they're different depending on which device it is. It may do different things and target different areas of the central nervous system. But so these devices, they're those that stimulate the trigeminal nerves or branches of the trigeminal nerve. And there are 2 of them that are available that do that. There's one device that's available that it stimulates the trigeminal nerve and the occipital nerve. So it's combined occipital trigeminal nerve. And that is also very interesting. That one is the one that's really just cleared for acute. It's called Relivion. That's the, I'm not sure I can say brand names, but it's hard to get around devices and not be able to say brand names. And then we have the remote electrical neuromodulation, also known as the Nerivio device. And that is a very interesting one because it's a armband. And so you have a headache, but you're using an armband and you're using arm stimulation to actually stop a migraine attack. And it does so by targeting the conditioned pain modulation and descending pathways. And so, you're stimulating your peripheral nociceptors to stop a migraine attack. And when used every other day, actually can work as a preventive. And the indication is now down to 6 years of age and up. And so that one is a very effective and has really some of the data is very close to that of the pharmacological outcomes in terms of acute attack management. So that is one. And then there's a vagal nerve stimulator, also known as the gamma cord device, and it targets the cervical portion of the vagus nerve. And that one has indication for migraine acute attacks, but also can be effective for cluster headache and other related conditions that we called hemicrania continua and paroxysmal hemicrania. These are conditions that are indomethacin responsive disorders. And then we have the TMS device. TMS has a lot of headway in depression and other disorders, but it can also be useful for treatment of migraine, both preventively and acutely. Initially had indication for migraine with aura, but the data also showed that it's also helpful for migraine without aura, and it can also be used preventively. So we have a number of devices that are available. Who may be best for using a device? I think there are a number of people, those that don't want to be on a medication or have intolerance to medications or are already on too many medications. Pregnant patients, we don't have good quality, with the exception of the remote electrical neuromodulation study. We don't really have good data on pregnancy, but you know, this is electrical stimulation and likely to be effective and safe for pregnancy. So these are things that can be used with medications. So you may be on a preventive therapy, you may be on an acute pharmacological agent, but these may be adjunct to the existing program that you're using. And this is something, the majority of these require prescription. So you do have to talk to your primary care or your neurologist or your headache specialist to get on one of these devices. If you have a pacemaker, I just want to say, if you have a pacemaker, that's something that's contraindicated, but other than that, it's generally something very safe to use.
I also just wanted to mention, since we've touched on pregnancy briefly a couple of times, there was a dedicated migraine and pregnancy webinar that we ran last month, for which the recording should be online if anybody wants to delve deeper into some of those pregnancy questions. So I know that my patients react a couple of different ways to devices. Some of them are really pleased that they're non-medication options, and some of them are very skeptical. What's your experience?
Yeah, you know, I think the cost, to be honest, the biggest problem with these devices are costs. I'm saying costs. And so it becomes a challenge for some patients because it's pay out of pocket. Now, this is changing. I'm not sure how things are in Canada, but in the United States, there are now some private insurances that are starting to pick up the cost of some of these devices. But generally speaking, it's pay out of pocket. I know that if you're working with Dr. Riggins in the VA system, then you get a lot of these devices as part of the TRICARE insurance. But generally speaking, cost is an issue. But patients are generally interested and willing to try these things. Because it's a device, you actually have to use it. So kind of just like going to the gym, in order to get the workout, you actually have to go to the gym. So you actually have to use the device. So adherence can also be an issue with the devices as well. But I think for the right patient, it's a great option. And it's going to be hit or miss whether it's going to be helpful for you or not. We don't have biomarkers or ways of testing whether something is going to be helpful for a particular patient or not. So that is a problem. But I mean, it's certainly worth trying because it's safe. I had one patient that was on opiates, literally on opiates, and was put on one of these devices and was able to get off opiates. And he's like, it was just fascinating. That's probably not a common scenario, but you never know. So it's worth to consider some of these treatments. And you know, I think in the future, we're certainly going to see more of these devices. The nice thing is I should mention that they're non-invasive. And so unlike some of the older devices that they were minimally invasive, and there's some of them that were actually, you know, intracranial devices. So these are very safe because they're non-invasive.
Mm-hmm. And I think having all of these kinds of options, because like you said, different people have different goals and comfort levels and things that are okay for them. This is why we work to develop other options that work for different people. Maybe Dr. Riggins, you can touch on some of our non-pharmacological options and what's new in that sphere for migraine.
Yeah, we definitely enjoy having our different therapies which have such a little side effects to none, but can be really effective. So example would be meditation, biofeedback, cognitive behavioral therapy. I know that there is articles available, research articles, which look at function MRI and see how brain changes to healthier with those behavioral basically therapies. So it's really nice to have them available. We do have resource page with American Headache Society, and that can be made available if someone interested, if someone doesn't have neuropsychology, psychology available for that. Very interestingly, just to add on device, this REN device which goes on the arm, now has these wonderful videos, including videos with our excellent psychologist, Dr. Don Buse, which comes together with this device. So I just recently discovered it and very excited about that. So it's kind of getting 2-in-1 of non-drug basically interactions there. So that's been great. And then I wanted to say that things like lifestyle, extremely important. So diet, we know that it affects us in the really significant way. And so there's a really way forward and to improvement with lifestyle modifications. It's shown in multiple studies, including our nice study with great name CHEMP, when kids did modifications and they really improved in all arms of this study. So sleep on time, diet, very important, healthy diet. We really don't like when our patients hungry, so we say meals throughout the day, healthy ones. So maybe don't go on the diet when someone doesn't eat for long hours. Sleep, we work with sleep specialists all the time, very closely, can really affect migraine attacks, and once we improve sleep, it can really help. So getting outside, even for a little bit, when it's bright light, maybe in the morning, few minutes walk can go a long way to help. So those would be examples of non-medication and which can be helpful. And of course, with and different sorts of lights and maybe some glasses. I really love when we have these shades for migraine day and we all go and advocating in our darker glasses for our patients. So those all something to keep in mind, can be very helpful. Just putting dark glasses which block this flickering light from computer and from outside.
Yeah, the best ones for those are the FL41s, because we don't want people to like wear too dark of glasses because there's a risk of increasing sensitization. But there are glasses that are designed for people with migraine that are out there.
Yeah, and I wanted to mention procedures. So that's another arm of our treatments, in addition to lifestyle, behavioral therapies, our medications. So our procedures can be in addition, for example, to everything else we're doing. And those include onabotulinum toxin, which approved for chronic migraine, 15 days and more per month. We do enjoy having occipital nerve blocks, which can be helpful for migraine, but also for cervicogenic component of headache, which many people can have. I also really like anything which doesn't have needle and can help, such as sphenopalatine ganglion blocks or SPG blocks. Now we have few devices which we can offer medication delivered without needle, and sometimes we have very good efficacy for those. So I wanted to to mention those procedures that can be really helpful when integrated in patient treatment plan.
Thank you. So that's kind of like a whirlwind view of all of the sorts of things. We didn't really touch on things like the nutraceuticals. We mentioned them briefly, but a whirlwind, this is the stuff that we do for migraine. So maybe we'll shift now to where should we go? Dr. Monteith, what are we missing here? What is it that we need to continue working towards in migraine?
Well, that's a big question. So what are we missing? I think we still have gained tremendous knowledge in or understanding of migraine pathophysiology, but there certainly needs to be more research in understanding migraine from a preclinical to a clinical perspective. But as you mentioned earlier in the beginning of this discussion, was about the benefits of migraine-specific treatment. And I think that finding better targets for people that are specific to their disease are important. There are a number of emerging targets that are available to research that are still in either preclinical models or early models that may be helpful for patients with migraine. So take, for example, the most recent phase 2 clinical trial, phase 2A clinical trial targeting PACAP. And this is a pituitary adenylate cyclase activating polypeptide. There are two isoforms, there's 38 and 27. And this was a paper that was published. It was a proof of concept paper. So a smaller study is looking at 2 doses and following patients, comparing their baseline number of migraine days to 4 weeks out. And it showed that there was a significant benefit when using monoclonal antibodies to target this polypeptide. So I think this is exciting and very interesting. And there is now an ongoing phase 3 clinical trial that is either ongoing or planned. And so we're going to find out more about the safety. So far, the safety data really looked quite good, but we're going to see how it looks in larger studies. So I think that when we have patients that have cycled through the CGRP inhibitors, they wonder, what's wrong with me? Am I an alien? No, you're not an alien. There are many, many different targets available for migraine. And we know that migraine is a polygenetic disorder. And so I think the future is really bright at looking at some of these more specific targets. It's not just PACAP, there are others. There are ion channels, there's the ATP potassium channel, there's a TRP channel that is out there. There are a number of other molecules that we can try and target, nitric oxide, glutamate, and so there are a number of things that are in the pipeline when we think about the landscape or the emerging landscape for migraine.
I think it's really important for patients to know that we didn't just stop at CGRP, because there are, like you said, some people who've been failed by those medications, and that's really tough to see people that having their lives changed and still be stuck in a place where migraine is so disabling. And so working towards all these new kinds of targets, I think, is important for all of those people that are still struggling. And so maybe, Dr. Riggins, you can tell us about some of the ways in which people can advocate to try to help push this field forward and help all of those people that still have those unmet needs.
Absolutely. I believe that what our patients saying, that advocacy should be in every patient treatment plan, that's very true. And for me, everything kind of circles around advocacy, because when we give education to students, to residents, to fellows, so interprofessional education, we create more advocates for our patients. And our patients themselves, such a wonderful advocates when we go to Headache on the Hill together. This is such an inspiration. So I would definitely invite the people who can join this Headache on the Hill advocacy. It's definitely wonderful. And this American Migraine Foundation education, also helpful advocacy. Then there is stigma. Very interesting article by Dr. Shapiro published and shows that stigma as much, if not more important, in effects on person's life and functioning as days per month of migraine attack. So that was amazing information, and we need to fight the stigma, and we can do it only together as medical professionals, but also working together with our patients. So our events with Miles for Migraine, our races, they usually bring attention, they bring awareness, but they also bring more resources for more education. And then research. So we looking, for example, for NIH funds, and we still need work more on that. So when we go with American Academy of Neurology, neurology on the hill, and then with again headache on the hill all together, we're talking about research very often and about dedicating more funds to neurological patients treatment and how to figure out new treatments. To the Dr. Monte point, what is in the future, we do have all these wonderful tools and receptors, but very often in the clinic, we hear that what would be the best for me? And we try to distinguish different markers, but it would be wonderful to have research as a result of this advocacy, which will give us biomarkers, which will give us indication, okay, this medication is great for this individual. So precision medicine and medicine centered around our patient, individual patient is the something which advocacy really needs.
Thank you. I think that's a really nice point. We need to be able to know better what exactly the right treatment for our patients would be, although we will still recognize that the patient is the one who makes the decision and we're the ones who advise and just help guide those choices. Dr. Monteith, any thoughts on advocacy for you before we move towards our next section?
Yeah, well, I think I completely agree with this. We really, advocacy means many things. It means going to Washington and trying to get research. It also means advocating for our patients and talking to our insurers about trying to get some of the best quality treatments that are available. It also means patients advocating for themselves and their family members, and that might mean different things. So integrating advocacy and being a part of the American Migraine Foundation, participating on this webinar and some of the other activities that are put out by the American Migraine Foundation is really part of it, because we're really a community and we do need each other. If we're going to move advances forward, patients need doctors, doctors need patients, family members need to be part of this, because we're all really searching for the same thing.
Thank you. Any last thoughts from either of you before we move to our flood of questions?
I want to use this opportunity. So many patients told me, and I hope maybe some of them even online and will hear that, if I have opportunity from many patients when we work together and we have improvement due to all our working, many people say, please communicate, do not give up. So I'm going to use this opportunity, do not give up, reach out to us and we'll work together. And it goes for other specialties. We love working with primary care, OBGYN, ENT specialists, and anyone who interested in helping our patients living with headache and migraine. And we also, it goes for our patients. Please don't think that you are alone. We are here and we want to help.
Dr. Monteith, any last thoughts?
Yeah, no, I think that was a great ending. I think this education is super important. Come back on our webinars. We have amazing webinars. We always have great speakers. And while we don't always have the answers, we will fight to find the answers. And so I think this is a great opportunity, and I'm glad that we have our listeners.
Okay, and so I hope that you will have some answers to all of the many really great questions that we've gotten. Like I said, we're going to do our best to answer as many as we can while not being able to provide specific medical advice. And I'm sorry in advance to anybody who submitted a question that we won't have time for. We're going to just start by somebody is asking, how can you explain to people like friends and family the difference between a bad headache and migraine? Because this is something that's hard for people to do and it can be hard for people to understand.
Yeah, I think that data about migraine and disability comes very handy, and it's been published in more recent publications also there. So there is very strong evidence that migraine is genetic neurologic disease. We don't use word anymore migraines in plural because it's there, it's affect life, person adjusting life because supposed to do lifestyle modification, think about triggers. So we very respectfully treating this disease and showing data that it's second cause of global disability, and showing data that addressing this disease can really work on every level, like workplace migraine, for example. We have very good data. It saves a lot of effort and actually a lot of finance for corporation, even when they address migraine and let person maybe have more flexible schedule, maybe adjust their life, so really treat it with respect. So we have available information for that, and I'm pretty sure American Migraine Foundation has it on the website.
Yes, so we do have some good resources for talking to people around that and helping people understand that it's not just a headache and that there are all those other impacts. Okay, thank you. So we're gonna take a grab bag of questions here. So someone is saying they have weather-related migraine attacks. Is there any new treatment on the horizon for this? And Dr. Monteith, you alluded to this already, unfortunately.
Yeah, unfortunately, we don't have that. I mean, I think that migraine is, as we said, a neurologic disorder. We define it often by the clinical symptoms, but there are many things that go into that pathway of getting to that migraine attack, and weather is just one of many things. And so you have the benefit, not everyone can, there's sometimes it rains. I don't know what type of weather change can trigger your migraine attack. For some people, it's right before a storm. For some people, it's when it's very hot. And so, but if it's very consistent for you, you may want to say when that weather headache of migraine is coming on, are there even any symptoms before what is a frank migraine attack? Maybe it's mild pain, maybe it's light sensitivity, those prodromal symptoms that we speak of. So I would say that if you identify your trigger, be on alert for these prodromal symptoms that happen before the acute migraine attack, because that's an opportunity to treat, identifying that has an important trigger for yourself.
Yeah, I wanted to add a couple points to this very interesting topic. One, for hot weather, I learned from our community that there is a lot of migraine heads, very nice looking ones. They call different names, and so they can cool nicely during heat. And then second point, that migraine being also considered disorder of thresholds. And so if we cannot avoid one of triggers, we would recommend to address triggers which we can address. So if someone has hormonally related triggering of migraine, and for example, around menstrual cycle, maybe in this situation, pay more attention to not get dehydrated, eat on time, get to sleep on time. So triggers cumulative, and we can avoid migraine attacks at times when we make sure that we doing all these lifestyle modifications and weather happens, and maybe with all this being said, there will be no migraine attack.
and this sort of leads into the next similar but different question. So somebody's asking if there is a way to reduce or eliminate the hereditary aspect of migraine, as many of their family members have this, and they're concerned about children who are now starting to show signs of migraine. Is there anything we can do about that?
Well, that's a great question. Really, the answer is no. I mean, you could do gene testing. Unfortunately, for they're very rare genes that you're going to identify as a risk. These are the hemiplegic migraines so those are very rare genotypes. And so you can certainly ask the person you're dating whether they have migraine, but that might change, And so I think the best thing to do is if you yourself have migraine and your offspring ends up having migraine, you could you could identify that, you can diagnose your child and make sure they get treatment early, because it's a very treatable disorder, and early diagnosis is really key to improving quality of life.
Yeah, if we caught everyone in pediatrics, I think they would have a different kind of life. We have to work towards that. Sorry, Dr. Riggins.
No, that's excellent point. I just wanted to say that it's very important to maybe consult our patients prior to pregnancy, that for many migraine might improve, not for everyone. But I looked at data that so many people living with migraine decide against pregnancy because they worry how they going to not take medications during pregnancy. And so we usually can support our patients with medication which better during pregnancy for them and baby, maybe with some devices or procedures, but also by the third trimester, many people will improve due to stabilization of hormones. So I just was burning to say that we can support, if someone wants to have baby, we can support it. And so please don't think that there is no help for this case. And second point, Dr. Gelfand and her team did great study about babies. They did a survey for multiple patients, and they did survey for parents and for colicky babies. And they show that maternal migraine may be associated with baby being fussy and little bit colicky, and so it takes away pressure on the mom. There is not something that done wrong, that's okay, and placing baby in nice quiet environment, just like what adult person would do with migraine attack, maybe just that. So just wanted to bring these two nice points out there.
Thank you. We're going to shift to some treatment kind of questions. This is a maybe fast one, but an important one. Someone is asking about, is there concern for serotonin syndrome with triptans?
Yeah, so I mean, it depends on what medication you combine the triptan with, but generally speaking, triptans are not associated with serotonin syndrome. The biggest question is usually combining serotonin SSRIs with triptans, and so there's been some review of that data and some of the FDA warnings, and it seemed to really not pan out. So if you're on an SSRI, it's certainly safe to take a triptan. And even the serotonin syndrome that occurs is not thought to be mediated by the same receptor that triptans target. So even more reason not to be concerned. While we can't say absolutely not, it's highly unlikely, and we don't think it occurs with SSRIs.
Okay, thank you. We've got a couple of questions about the sort of long-term effects of some of our CGRP monoclonal antibodies, for example. Is this something that we expect to continue to be effective over time, to lose benefit over time? Do people get used to these medications?
Yeah, so
studies which show, sorry, go ahead.
Well, I was just going to say that you can see different things. You can see response, you can see non-response. And then when you see response, oftentimes there's actually a functional cumulative response that the longer you're on the treatment, the better benefit you have. But these are not disease-modifying therapies, so that if you stop the therapy and you're doing well, there may be a portion of people that relapse back into their high frequency or even chronic migraine state. And they seem to be very safe over long periods of time.
There's also a question about long-term impact of onabotulinum toxin injections. Any thoughts? Is this likely to continue to help? Are there any concerns long-term?
Yeah, so onabotulinum toxin A, well, FDA approved in 2010, but used even before then. And there's really no concern of long-term side effects associated with appropriate use of onabotulinum toxin for chronic migraine. So very safe to use. Now, the question is, do you need to be on it if you've been extremely well controlled for a very long period of time? There's certainly people that I'm able to take off and they do just fine. And then there's some people that we take them off and over a period of time, a year, 6 months, their migraines may return. So it's a conversation, and this requires a holistic, approach.
And action can improve, like effects can get better with Botox. There is research showing that with time, maybe first it's like really migraine attacks go steeply down for some people, but then it's continues slowly decrease over time, which was very happy study to see.
Thank you both. In the last, we're down to the wire here, we're going to have a couple of GPANT questions. So there's a question about why the number of pills per month that people get is limited. Is this because of safety? Is this because of medication overuse concern? What is going on here?
Yeah, well, generally speaking, it's based on safety and what was studied in clinical trials. And so, so then there is a limitation. Some of this might also be related to costs. For example, and you could always, depending on what drug you're on, you may ask for more. For example, ubrogepant, which is typically administered with 10 tablets. Some insurances are willing to pay up to 18 tablets of ubrogepant. So that's something to be mindful of. And with rimegepant, now that we have the preventive indication, patients can get up to 16 or sometimes even 18 pills of rimegepant.
Okay. And there's also a question as to, do we know why one GPANT may work for someone while another doesn't?
Yeah, so that's a great question. And, we don't have the answer to that. Even more broadly, why do some people respond to triptans and don't respond to triptans, and those respond to GPANTs? And so I think that these drugs are not the same drugs, right? They're made by different companies. They're different pharmacologic agents. And so we have some people that respond really well to one and not to the other, or they respond to both. And so I think that's a great point, which is that if you don't respond to one, then that doesn't mean that you're not going to respond to another. And now we have 3 acute GPANTs that can be tried, including Vigezepant, which is a nasal spray.
Okay, so I think we have time for, I'm going to ask each of you for one small sort of takeaway closing thought to end our webinar. That can be anything that you want to say based on our conversation so far or the questions that we've had. Dr. Riggins?
Yeah, I would say my takeaway point that community of migraine warriors very important. We learn from each other and we work on getting functioning and life without pain better.
Thank you. Lovely sentiment. Dr. Monteith.
Yeah, I would say that this is a very exciting time. No one wants a neurologic disorder, let's just put that out there, but now it's an exciting time because there's so many treatment options and opportunities for personalized, individualized care. The non-pharmacologic opportunities, the pharmacologic opportunities, the treatments that are now more migraine specific can really be tailored. And so do not be discouraged, and recognize that this is oftentimes incremental care. Sometimes we can make massive leaps between your first appointment and your 3-month out appointment. And sometimes it does take that incremental care and that fine adjustment to really find what works best for you. So be excited, read, go on the American Migraine Foundation website, bring things to your doctor that may not be up to date with some of these newer advances and treatment. And again, do not be discouraged, because there are a lot of people that are working on this, and there are a lot of opportunities for improvement.
Thank you both so much, and thank you for the great discussion. Thank you again to all of our audience for being with us and for the really excellent questions. As Dr. Monteith said, please do visit the American Migraine Foundation for a lot of great resources, and you can follow us on all of the major social media platforms for more interesting learning. Thank you so much for joining, and we hope that you enjoyed this webinar. Have a great evening.